We have Claudia, who is also a great surgeon. Uh, I met her a couple of years ago, and she's finishing up now her training, and she's also our hospital, well, our La Familia Eye Center director as well. So she does a great job. She works in Guatemala, and she flies to Nuevo Progreso, and then she comes back, and then she's all over the place. Um, Claudia, do you still have your a clinic in
Mula?
yeah?
Uh, Not really. It was never my clinic. They used to call me whenever they had some surgeries to be done.
Oh,
So
so
maybe
you
I
still,
just go once a month or twice a month
yeah.
or whenever they have any surgeries to be done. So yeah, but I don't go that often as I used to.
Oh, okay. So take it away.
Sure. Can everyone see my screen?
Yeah.
Yes.
Okay. So good evening, everyone. So I have no disclosures for this meeting. I'm gonna start presenting you a case of a 54-year-old lady that came to No Progreso Clinic last year. She came with a really bad fungal keratitis, and we were just about to do a conjunctival graft because she had a 100% melting of the cornea. But in the moment that I was trying to scrape some of the epithelium, I had a big perforation, so I had nowhere place to put a scleral patch over that perforation and that melting. But I had some tissues from Kanika's agarwal trip in February of that year, and I used one of those tissues to perform a tectonic keratoplasty on that opportunity. So this is the picture on the left side. It's like on post-op day one. I was really surprised that she has a chamber formed. And the picture on the right side, it's like 2 or 3 weeks after the procedure. And as you can see, there are some loosened sutures and some vessels growing around those loosened sutures. And because he had so many loosened sutures, they were replaced in the OR that opportunity. So the patient did really well. It was kind of different treating tectonic tissue than optic tissue because you don't really know how much steroids you can put because you know that there was an active infectious uh, condition in that moment. But fortunately, the patient did really well with some mild steroids and a lot of antibiotics. And this is the result of that cornea almost a year after the procedure. So as you can see, the tissue is completely attached to what was left of the cornea. There's no sutures left on that button, but you can see there's like a wide neovascularization over the cornea. Uh, she was scheduled for a corneal transplant last month, but unfortunately, because of the lack of tissues, and we have to select some other patients that were more urgent than her, uh, we decided to postpone the surgery. Hopefully, we will do it on April. And in the meantime, we try to apply some subconjunctival anti-VEGF over two areas in the areas where there, as you can see, there are two complex of neovascularizations in the temporal and in the inferior side. So this patient is yet to be seen. I'm basically going to talk about the management options for corneal vascularization. first need to talk about the ways of how corneal vascularization is done. So this is a relatively common consequence of severe ocular surface and corneal pathologies. It always has to, there has to be an stimulus, either if it's inflammation, hypoxia, innervation disorders, neoplasia, and limbal stem cell deficiency. Uh, the attraction of the endothelial cells are mediated by chemokines for macrophages and endothelial cells. Then all of these cells migrate due to the degradation of extracellular matrix and basement membrane matrix metalloproteinases. And then all of these vessels, once they all know the ways to go, they have some other additions and stabilizations of the vessels. How do we evaluate the vascularization of the cornea? First, we have to know the source of the vessels. Either they are from the conjunctival, from stromal, or from the iris. We have to check the vessel penetration depth, the branching, the leakage that might cause lipid exudates. Uh, most of the time, these vessels, as you can see in the picture, they grow in loops. So there is an afferent vessel that is narrower, straighter. It is on the deeper layers of the cornea and it is bright red. And there has to be a drainage or an efferent vessel, which is going to be large from a large caliber and it's going to be dark red. These loops may appear and disappear as vessels fan out because they will be constantly remodeling of the vascular channels, and this will depend on the stage of the treatment or the disease. As you can see, the picture on the left side is an active inflammation. So in the picture on the right side, the inflammation is mostly done, but the branching of the neovascularization is different in both stages. They can grow some complexes and feeder vessels, and most of the time they're going to be multiple or single. But most of the time we're going to find multiple feeders of these complexes. Vessels will follow planes. It might follow suture tracks, incisional planes, either to heal scar lines of lacerations, grab house junctions, arcuate incisions, also can follow lamellar planes from deep lamellar keratoplasty and endothelial transplants, as you can see on these pictures. Really important, as I was saying at the beginning, suture will attract vessels, even if they are broken, loose, or too tight. So even if it's like post-op day one of a corneal surgery, and if we see a loosened or a broken suture, we cannot leave that like that. So we immediately have to replace it in the OR. Some other corneal pathologies that might have this neovascularization are going to be congenital diseases, contact lens related hypoxia, inflammatory diseases, chemical burns, limbal stem cell deficiency, allergies, trauma, infectious keratitis, autoimmune diseases, and corneal graft rejection. But a non-inducer of corneal angiogenesis, but that cause inflammation, is the infection of acanthamoeba, which is interesting. As you can see on the pictures, there will be no growing of vessels. Vessels will follow the depth of the stimulus. So if it is superficial keratitis, the vessel will be more superficial. The same as if they are stromal keratitis, vessels will be deeper. Or if there is like a vessel encroachment, as we can see on Penus, these vessels will be over the cornea rather than inside of the cornea. The vessel activity, we might have these stages. We might see an active jump where you can find these bright vessels, which are very red, and a lot of inflammation surrounding the area of the spot of the inflammation. We can find then an active all, which are less red, but still circulation can be seen and some edema. Then they can regress or part regress, and we can see the still circulation but not leaking. Or we can find circulating but and leaking lipids. And when we find a completely regressed vessel, there will be no circulation over the on the vessel, which we will find these ghost vessels. But whenever the stimulus comes back, they can get recanalized. So we don't. Most of the time, we think that if we find these ghost vessels, the inflammation is done, but we have to think that these vessels can be recanalized if the stimulus comes back. So speaking about the medical management for the corneal vessels, we will have medical treatments, some surgical treatments, or combined treatments. Starting with, which is like first line of treatment, we have steroids. They say that cortisone, dexamethasone, and prednisolone will be better for inhibiting cell chemostasis and inhibiting pro-inflammatory cytokines. They also cause lymphocyte death and inhibiting vascular dilation. The use of steroids such as cortisone in conjunction with heparin and cyclodextrins causes a greater anti-angiogenic effect. And we use oral and systemic corticosteroids associated with systemic inflammation, autoimmune diseases, or in graft disease or corneal transplant rejection. NSAIDs primarily work by inhibiting cyclooxygenase, which is involved in prostaglandin synthesis. They might be only useful just to stop inflammatory process that might lead to the corneal neovascularization, but we cannot use NSAIDs as a primary treatment, just like an adjunct treatment. And as we know, we should use it with caution due to the complication that may cause as corneal ulceration, melting, and then neurotrophic keratitis. The most commonly used to prevent the neovascularization are bromfenac, nepafenac, or diclofenac. We can also use VEGF inhibitors. But these are going to be more useful in newly formed vessels. They exhibit a good response in contrast to mature vessels in chronic neovascularization, on which these drugs are going to be less effective due to the abundant pericyte recruitment to the angiogenesis sites. Either can be used in topical or subconjunctival treatment and has shown a significant reduction in vascular areas in patients with corneal transplantation. How much of the Avastin or anti-VEGF can be used is the same amount like as we do use in intravitreal injections, and we can administer it in every quadrant of the neovascularization subconjunctival and can be administered every 2 weeks until we see some response. Another immunosuppressive drug, cyclosporine, it inhibits the production or release of pro-inflammatory cytokines, including interleukin-2. The topical dosage of 0.05% causes corneal stromal neovascularization regression and reduces the corneal graft rejection risk in selected cases, but using it as 0.1% is more effective in inhibiting newly formed corneal neovascularization, even more than the bevacizumab eye drops. But it might have a proangiogenic effect during wound healing and may promote new blood vessel formation in tissue repairs. that inhibits the expression of PGF. So it's not useful in every case, or not at the beginning of, like, for example, a new corneal transplant, because we need these wounds to be healed before using it. Some other medical therapies as tacrolimus, rapamycin, and in some studies they mention losartan, because even if it doesn't have like this um, angiogenesis protective, but it will reduce the corneal scarring, which may be useful for inhibit the formation of neovascularization. There's also this new gene therapy for corneal vascularization, which what they want is to introduce modified genetic material to regulate the expression of specific genes associated with neovascularization process. And this might include the introduction of genes encoding inhibitors of vascular growth factors as endostatins or angiostatins. Some studies to be done yet, but I think that at least in our country, we are a little bit far away of using this kind of therapy. Getting into the surgical treatment, the fine needle diathermy is done by performing using a 3/8 needle with a 10-0 nylon suture. It is done by inserting the needle close to the limbus parallel to the vessel and at the same time at the same depth as the vessel to be closed. And diathermy is continued until a mild widening of the corneal stroma, as you will see on this video. It can be performed on different sides of the cornea depending on how much neovascularization is, and you have to use a monopolar tip cautery over the edge of the suture until you see this mild white haze in the cornea. It might disappear in 24 or 48 hours. And as in this case, they are also combining anti-VEGF in different quadrants. And they will use also triamcinolone at the end of the case. So basically, this is a really safe procedure to be done. Either way, the use of the cautery may cause angiogenesis. So we have to check the patient like really close to see if there are not gonna be any more complication or side effects after this. But most of the time they say that it is really safe to be done. Laser therapy was really popular in the 1975. They used to do argon laser photocoagulation and a 575 nanometers yellow laser. It is used to obliterate abnormal blood vessels in the cornea, preventing the flap rejection or treating the lipid keratopathy. Facilitates the obliteration of a large diameter and slow flow efferent vessels, but it wasn't that useful in the vessels that were afferent because they were more narrower and really hard to be seen for the spot of the laser. But the thermal damage due to the repeated use might promote also the neovascularization recurrence, and some complications of the argon laser are the corneal endothelial damage, corneal thinning, intraocular hemorrhages, pupillar displacement because of the iris atrophy that might be caused because of the laser goes a little bit farther than the vessel, or a corneal suturolysis after PKP. The JAG laser photocoagulation has reported no significant side effects, and in this study, after the 3 months after the completion of frequency double YAG laser photocoagulation, the corneal opacity area and corneal neovascularization area reductions were 77% and 44% respectively. So it's something that we can try. So, there's also mitomycin C intravascular chemoembolization. Mitomycin C restricts the ability of vascular endothelial cells to proliferate, which in turn limits the blood vessels endothelial monolayer's ability to heal. The dosage is 0.4 milligrams per milliliter. It's used to partially fill a 1 cc syringe fitting on a 30 gauge needle. Has to be done injecting the greatest bore corneal vessel identified immediately inside the limbus and a volume of a 0.01 cc to 0.05 cc completely intrastromal to prevent the escape of mitomycin C to the ocular surface. This should be done in the OR prior applying povidone, tetracaine, and after that, irrigating a lot of BSS after the application of the mitomycin C and applying some antibiotics. You can see on this video. We can also try with amniotic membrane transplantation, but this one is more useful in cases of chemical alkali burns of the cornea because it can inhibit the development of corneal neovascularization. Also may inhibit the growth of fibrovascular tissue and the formation of neovessels, and may be beneficial for the treatment of early stages of severe alkaline eye burns. So what they say is that it won't be that useful in cases where it's a long-term disease. So this is something to have in mind in cases that has less than 2 weeks of presentation. Superficial keratectomy. The idea is to remove epithelium, the Bowman's membrane, and superficial corneal stromal layers. Also can be combined with intraoperative 0.02% of mitomycin C to reduce the pulse of corneal haze, or amniotic membrane transplantation to improve surgical outcomes. And also, most of these treatments can be combined either with subconjunctival injection of bevacizumab or topical treatments and laser treatments. Last year on the ESCRS, this doctor presented this potential use of cross-linking to treat neovascularization. He had a small case study involving just 5 human patients, similarly noted significant regression of mature vessels in all eyes after cross-linking. In other studies, 6 eyes that receive accelerated and high fluence of cross-linking for neovascularization also demonstrated significant reductions in total vessel area and vessel length without adverse effects. And based on this positive early data, Germany recently approved the cross-corneal vision study, a 5-year prospective randomized multicenter clinical trial that will explore the use of cross-linking to reduce corneal neovascularization and improve graft survival in high-risk patients prior to keratoplasty. So this is what I was gonna bring you tonight. I intended to talk about this topic because we have a lot of patients in where we not only in Nuevo Progreso but in the whole country with bad corneal vascularizations due to all of these conditions that I already spoke. And that's so little information on what can be done to this patient in order to prepare them to penetrating keratoplasty. So we were starting on January with Dr. Kapoor with some patients to put some Avastin, and maybe we can try also the fine needle diathermy, or maybe the chemoembolization with mitomycin C. So to know that we have all of these options, and this is what I was bringing to you tonight. I'm gonna stop sharing my screen. If you have any comments on this.
Hey, thank you, Claudia. It's actually a great presentation. Haven't heard of most of those. I'm not a cornea specialist, but it was really, really great to learn all that. Thank you.
Thank you.
Hi, Claudia, and hi everyone. I just wanted to share that in Hospital for Roble, we have maybe like 5 or 6 patients that we treat with the chemoembolization with the mitomycin, and we use it in pediatric patients with the basils that were like very big. So we saw a really good response with them. I'm not in Robles anymore, but they told me that when they made the follow-up, they saw a really good regression of the basils. So it is really nice, and it's easy to apply the mitomycin with the needle in the intrastromal basils. So it's I had a good experience with it.
Yesenia.
Thank you.
Anybody else have a comment? Any other cornea specialists?
Claudia, this is Andy. I'm really
Andy.
sorry I missed the first. I'm sorry I missed the first 20 minutes, but the last 10 minutes was a great review of treatments. I must say, in my experience, I've certainly had a mixed success rate with cautery, with Avastin, with another technique when you're doing the transplant is cutting the vessels and putting thrombin flakes as a way to coagulate the vessels. But I just wanted, the only thing I wanted to say is that having a failed transplant with blood vessels all over it is worse than having a cornea scar and blood vessels in it. So I think until you've convinced yourself that you have a technique that's reliable, maybe the one Xenia just talked about is that technique. But until you have convinced yourself, I'm just always really hesitant to do a transplant in an eye where I think it's going to become highly vascularized again, because now you have an eye with a transplant and no vision. And that's a lot that's more dangerous than having an eye with just the vascularization. So that's just my thought. But it sounds like you're doing some really good work and trying to restore vision in these eyes with pills, and that's I think a lot of work ahead in that area. Thanks for presenting on that.
Thank you, Andy.
I took some time to unmute myself on my phone. I don't know what's happened. I couldn't find it, but that was a great presentation, Claudia.
Thank you.
I like Andy, have had mixed results. I've done Avastin subconj injections, And sometimes they've worked and sometimes not. I have tried the mice procedure and I didn't have much luck with that. I special ordered the 32 gauge needle to inject directly into the limbal blood vessels. Sorry, the corneal blood vessels, but it was still too big. So my experience so far is that you have to have really large enough blood vessels to inject the mitomycin C into. Otherwise, it didn't work with me. So I will keep trying. I'll look for patients with big juicy vessels to inject into. The other one that I didn't see mentioned is Avastin drops. That is, there are some case reports of using Avastin as in a drop form rather than just subconjunctival injections, which can be a little harder for some patients to tolerate. And so the drops are an alternative. I am going to look into offering that to my patients. I haven't done it yet, but just something else to consider. The cauterization in my hands hasn't worked. The most luck I've had is with sometimes chronic steroid drop usage, the subconjavastin, and I'm doing a little study with losartan drops, and I had a patient with lipid keratopathy and pannus, and using the losartan made everything disappear. I was using it for a scar, but it made everything disappear. The vessels are gone, the lipid keratopathy is gone, and her scar is better. So that's my N of 1 for that.
Thank you.
But yeah, that was a great review.
Thank you, Claudia. Thank you, Seema, and everybody. Yeah, it was a great review, I guess. I don't have that much experience with those neovascularizations or that, but yeah, it sounds like you're doing great, and let us know what works. Let us know what you tried, and you know, if you try doses or different areas, trying Avastin or trying or Avastin in drops, that also might work, you know.
Yeah, I have now a new few ideas for some specific cases that we have in Nuevo Progreso, so I will let you know.
I recall one patient that we used here in the clinic, losartan, for a
Corneal haze and scarrings.
corneal haze after a herpetic keratitis, and it has worked. Her vision has come back from 2100 to about 2050, and it really works. And there is a pharmacy here in Guatemala that can make it. I mean, they have the original medication, so they don't grind
La materia prima.
the pills. So they just create it from it's fluid, it's clear, it burns a lot, but they don't grind the pills. So it works. I can give you the information if you want.
Please, you do, because we were also trying the losartan drops in Nuevo Progreso, but we were using the pills.
No, I'll send you
and then I found out that using the materia prima works better than using the pills.
Right, yeah. I can send you that information.
Thank you.
All right, everyone. No other comments. Thank you for joining in the discussion. Thank you, Claudia, and everyone. Good to see everyone. And I'll see you next week.
Good night.
Thank
Good
you,
night.
everybody.
Bye, Andy. Bye.